Hi folks, I'm Laird Landon. This is the second video in our three-part series on how doctors and caregivers can work effectively to provide service to the person with dementia. This time I'm talking specifically to doctors about how they can facilitate working with the caregiver to do what's best for the clear that I am not a medical doctor, but I've spent many years working with caregivers, so what I'm going to describe is coming from their perspective, and I think it might help physicians choose their words and manage the visit a little more effectively. First, I want to quote from a Master's of Public Health thesis, where a candidate researched caregivers and their perceptions of how the physician engaged them and the quality of that engagement. And then she evaluated not only that global judgment on a rating scale, but also the components of the visit. And this is her conclusion. Quote, "The highest two correlates of global satisfaction with a physician are perceived emotional support and provision of links to social support." That is, if you as a physician can show that you have emotional empathy for the caregiver, and you can provide just a few links to where that caregiver can go to get further support, you're a winner. Let me give some suggestions then. At the very beginning of the visit, acknowledge the caregiver's presence. Don't ignore them. Don't focus only on the patient. You may want to, but at the beginning, acknowledge the caregiver and say, "Thank you for coming." Second, later in the visit, turn again to the caregiver and say, "Do you have any thoughts or anything to add to what we've just done?" And finally, check for caregiver burden by saying, "How are you doing?" And listen. And you can judge the degree of caregiver burden. If you don't ask the question, you only have your observation of them. And they may be tuned out looking at their phone, they may be sniffling, whatever. Ask them directly. Not only does it give you good information, but if you have touched that caregiver 3 times during the visit, they will feel included, they will feel appreciated. Another thing you might do, if it's appropriate, if you can see some tension between the patient and the caregiver, you might, on the way out, quietly suggest to the caregiver, "Why don't you make another appointment and come in and talk to me alone?" The truth is, as we mentioned in the previous video, sometimes taking that triad and breaking it and talking two people together is much more effective. And if you do that, you will further create a bond with that caregiver to make them appreciate that they're included in the process and they have an avenue to talk to you individually about what's going on. The next set has to do with the second part of that general conclusion from the MHA thesis, and that is providing links to social services. It is unfortunate in the extreme that some physicians have no suggestions to make to caregivers. They may not have been exposed to it. I want to give it to you now and suggest that the caregiver should not leave that first visit or the diagnostic visit without giving them a link to something. And there are many. It takes little time to research. The first and most obvious is the Area Agency on Aging. It covers the entire country with federal and state money designed to support seniors and most, as we know, dementia patients and caregivers, are over 60, and the Area Agency on Aging Services are available to them. Please find the local number of the Area Agency on Aging region that you live in and have that number available for the caregiver. Second, licensed clinical social workers. This is probably one you refer to already when a caregiver expresses great turmoil and being overwhelmed by the process. Social workers are trained to give plenty of time and room to let people understand what their feelings are and start to begin to process them. There is, however, one other option, and that is a support group. And support groups, many caregivers feel, is the most significant support they receive throughout caring. It is because the group has other people in it who are going through the same experience and they can share. Further, it has a facilitator who has been through it a lot and probably knows more about caregiving than most licensed clinical social workers, even though those facilitators may not be licensed. They are peer facilitators and can help a great deal. Home care agencies also can help. These are people that have folks that will come in and do light housekeeping, do adult daycare, and allow the caregiver some time off and relieve their burden a little. Churches can help too. Many churches have people who are helping families in the organization. Finally, on support groups, our organization, the Caregiver Support Foundation, has a Zoom group that is open to anyone with a computer that has the Zoom app. And if you go to our website, family-caregiver.org, you will find a way to contact us to see when those support groups are held and how they can connect with a link. Another area I'd like to talk about, and again I want to reiterate that I'm not a medical doctor, but I'm talking to you from the caregiver's point of view. And I implore you to use common English when you're talking. And I want to talk about a very fraught word, which is the word dementia. This word has changed meanings at least 3 times over the last 100 years. Before we knew there were brain diseases that caused dementia, that is, 1900, the term was senile dementia, which meant general dementia or failing of the mind caused by age. Now that, of course, we find there's a disease, we call the disease category or umbrella dementia, of which the causes could be Alzheimer's, Lewy bodies, Parkinson's, and there's a raft of them. But what this has done is, by changing the meaning and by the tremendous success of the Alzheimer's Association, more of your patients know about what Alzheimer's is than know what the word dementia means. So please, spend some time if you want to use the word. By that I mean, say something like, dementia means the brain is not working properly and it's not just aging. That leads a caregiver to say, oh, is it Alzheimer's? And then you can say, there are many causes of dementia and we need to do some more testing to decide exactly what the cause is. One final note that you may not have heard of. I read in a medical journal in England that it is common there to not use the word dementia at all, but to use the term brain failure. Now I know medicine has, and I'm not an expert in it, there is a specific kind of event in the brain that is often called brain failure. And I'm going to complicate that definition a little bit by saying Your caregivers understand what brain failure means in this situation, because they know what liver failure is, what kidney failure is, what heart failure is. And in each of those things, the term means the organ under question is operating less than it should be. Exactly what the cause is of kidney failure, or liver failure, or heart failure isn't specified, and it could be one of a number of things. Isn't that completely analogous to the way we use the term dementia today? So consider that. We have caregivers, beginning caregivers, come into our group and say, "What is dementia?" And I know you tried to explain it, but that doesn't mean they heard it or understood it. A couple of other terms. One is, it's common throughout medicine, especially in assessing pain, to describe it into 3 stages of mild, moderate, and severe. I suggest with caregivers to use different terms. Use early, middle, and late. They are preferred by caregivers. I remember vividly when I was told that Marilyn was in the mild state of dementia. You can imagine, from my point of view as a caregiver, there was nothing mild about it. In many ways, her early stage was more difficult on me as a caregiver than it was later when she had less capacity and was closer to the end. A final thing on using plain English. Suggest at the appropriate point, which is often early, maybe not on the first visit, but early. Now is the best time to plan with your loved one and family, because in the future, your loved one will be less able to participate. Early planning of things like advance directives or end of life. In the middle stage, very important to get a care plan that includes end of life, because the caregiver may not actually be in the room when the person dies, and you want that care plan to be specific so that the family isn't distraught, not just by the death, but by the type of care they received at the end. And a final suggestion, ask the caregiver, do you have a friend that will listen without judging? Just like grief, which is a major component of caregiving, both before and after death, having a friend who doesn't try to tell you what to do, doesn't try to tell you to get over it, doesn't try to say, "I'm really sorry," as they back out of the room. If we have just one personal friend, maybe it's in the family, but very often it's not. It's a neighbor, a social friend. They can be a lifeline, and you can help the caregiver by finding that person. I hope some of these ideas are useful to you. Thank you. And now I'd like to turn to talk to caregivers about things they can be more effective on the office visit.